Hello.
Welcome everyone. We also have a live audience with us today in the London Dermatology Centre. My name's David Ware. It's my great pleasure to be hosting this meeting. We're pushing the technology to it's a little bit today. I'm here with me our expert speaking, a consultant. And I'm just going to bring her on screen now. Okay.
Hi, good evening. I'm Dr Abirami. I'm one of the consultant dermatologists. I'm practicing around Kent in London. So thanks for joining this evening.
Okay, thank you very much. I'm going to know that you also on present, and then I'll offer to take you through the student slides.
So thank you for inviting me to speak about dermascopic and clinical terms and skin cancer. Hope that there's lots of useful take homes for all of you. So next slide, please. A bit of background about me. My interest in dermatology started in Erasmus at medical school in Liverpool. I did my speciality training in South Wales. I've got to give you a breath and beacons there, just about an hour from Cardiff. And then I did my training in 2023, and I've been working in and around London. So very excited to talk about this topic. I'm going to speak today over the next 45 minutes. What I have to talk about these next slides, these areas. So we're going to discuss the burden of skin cancer, and then my approach in my skin cancer clinics in assessing risk factors for skin cancer, recognizing types of skin cancer, and then we'll go through some clinical and dermoscopic pearls, and finish off with some cases. So just a little bit about the burden of skin cancer. This is now rising faster than ever. 15,400 people diagnosed with melanoma in the UK per year, and the incidence of melanoma is rising faster than any other cancer. Over the last decade, the number of people diagnosed with melanoma has nearly doubled. And interestingly, since 1997, there's been an increase of 155% for over 55-year-old patients, and 63% for under 55. So disproportionate increase in the old population is thought to be because of access to holiday now. So we don't just get sunshine in the summer season, but throughout the year. So we've got more UV radiation. Melanoma is the fifth most common cancer in the UK, and as we're probably all aware, BCCs are the most common cancer, even if you combine all other cancer types together. Males to females affected 1-to-1, and whilst melanoma treatments have transformed over the last decade, morbidity and mortality still exists, and really early detection improves outcomes. That's the beauty of the skin, that you can see these lesions when one's diagnosed without doing any investigations. Next slide, please. So this data was quite interesting to me. We can see the annual incidence of these skin cancers, BCCs, being 75,000 a year. But often for an average GP, they might diagnose one a year. For SCCs, 25,000 per year. But for an average GP, they might diagnose one every 1 to 2 years, and then melanoma one every 3 to 5 years. So we'll talk about the skills of assessing lesions and the importance of competition and seeing a large volume of cases, so you can consolidate the things that you learn. But I think it's quite interesting that reflection, we think of changes that we see. Yeah. So next slide, please. So let's talk about the three skin cancer and how they present. Typically, a melanoma will present as a new or changing pigmented lesion in the skin. Rarely have you had a mucosal melanoma presenting in the mouth, in the rectal area. Some melanomas are getting on friends with abnormal pigmentation in the nail, and this can have a high mortality. It's often missed. So abnormal pigmentation under the nail with Hutchinson sign, which is pigmentation leaking onto the skin, signs to look out for. And then let's not forget that melanoma can also present as metastatic disease in some places of unknown primary. So anyone with a suspected melanoma should be referred on a 2-week wait to suspected skin cancer pathway. Next slide, please. We've got squamous cell carcinomas. So these are typically presented in rapid history, weeks to months, growing tender ulcer or stone. And that tenderness is quite key for SCCs. Typically, these are sun exposed sites, the face, top of the ears, back of the hands. It's quite common. It's not a diagnostic path. You've got inflammation around SCCs, often redness around inflamed nodule. I'm going to be extra careful for lesions arising from chronic inflammation, scarring or Bowen's disease. So in the most recent 2020 SCC guidelines, SCCs arising within chronic inflammation or scarring or Bowen's disease are giving a high risk staging. And again, any suspected SCCs, you want to refer on the urgent suspected skin cancer pathway. Next slide, please. And then over to BCCs. There are different subtypes, so I'll just go through presentations with your ulcerated BCC. The patient might describe a non-healing wound. If you click, there should be an animation. Yeah. But so that's a typical ulcerated BCC there. Superficial BCC next. They will present as a persistent red scaly path, and you can see. Yeah, that's a superficial BCC. So you stretch the skin out, it's another tip because there's shading on the surface, superficial erosions, scaly red plaque on the skin, and then nodular BCC because they can be subtle. Lesions, ill-defined borders, and when these long that kind of margin and higher rates of completism. Again, usually BCCs are arising on sun-exposed sites, and those who are suspected to have this cancer, you all found routine or very well. So that's a nodular BCC. You see that early.
Lorraine Davis and who's what. She's not getting it. So I'm not sure of that. That we are. Yeah. We are live. We are live. All microphones are working. The slides are working. So this is actually the problem with the just through.
Next one. It's more BCC. You can see less and less well-defined margins. That's it. So, based on those findings, these are a few clinical plans. I teach a lot of junior doctors and registrars, and in my skin cancer clinics, it really still comes back down to those simple principles and foundations. So, a patient who describes bleeding, crusting, leading, I think that's a BCC to improve. Otherwise, stick and again, and then patients who are describing kind of a week to a month. This happens to be an SCC, it's a guideline, and it's the next click. And then melanomas, you think about any new or changing pigmented lesion next to it. Now, this is where the ABCDE rule comes in very, very useful in its clinical treatments. So just a simple way to differentiate between different types of skin cancer, let's sit. So this is the ABCDE rule. It's useful for yourself as an algorithm when you're assessing lesions, but also I get asked all the time by patients how much it involves. So it's a really simple algorithm. A being asymmetry, I can use the analogy of a pizza. You fold it in half, the toppings on the two halves of the pizza are they similar and the same? Border, is it smooth or is it blurry and jagged, which are red flags? Melanomas typically have multiple colours in them: browns, blacks, whites, reds. So multiple colours is a red flag. Diameter, this is a bit of an arbitrary one because melanomas can happen of any size. But the idea is the bigger the lesion, the more likely it is to be a melanoma, and E evolution. And this is what's useful to go by the other duckling sign. So when a patient presents with a specific mole, they want to look at to have glance at or their immune to see the other moles, because that gives you two things. It can help you to feel reassured about anemia. You might have some slightly abnormal features because you find that other moles will behave the same way if they're benign lesions. But also, when you compare against other lesions, you might find that the index lesion does stand out and is an ugly duckling, and that can reinforce the abnormality of that lesion. Next slide. I then would move on to risk factors of childhood burns and one history of sunburn in a child and teenager, down the risks of melanoma. Same with sunbed use. Use of a sunbed once under the age of 35 increases your melanoma risk by 75%. You want to get a gauge of the skin type of your patient. Type 1 Fitzpatrick being the highest risk. And then find out if they're immunosuppressed or have any hematological malignancies, because this will reduce the immune defense against skin cancer and make those skin cancers more aggressive. I see a lot of golfers and gardeners, construction workers. These people spend a lot of time outdoors. So you want to ask for occupation hobbies and living as well. Next slide. So just a reminder of the Fitzpatrick scale. Really quick way to know someone's type 1 is if they only burn in the sun, it means they're Fitzpatrick type 1, therefore the highest risk. And the more melanin you have in your skin, the more protected you are against skin cancer. Next slide. So why is dermascopy, why does it matter when you've got kind of useful clinical clues when you assess lesions? Well, there's plenty of studies now, a lot of data to support the fact that dermoscopy increases diagnostic accuracy by 25 to 30%. And even then, why does it matter? Well, I think for a lot of us, the guiding principles often been if and down, cut something out. And the idea is that, well, if you're reducing that level of down, you're actually making a better clinical decision. You're reducing the number of biopsies and excisions on benign lesions, and reducing the number of referrals. So it really does push that level of confidence up when you're assessing lesions. And I think the most useful, I find, use for endoscopy is its differentiation between a pigmented lesion and a non-pigmented lesion. That's where it's most useful. So we'll talk about some cases. So next slide. So this, I had a supervisor who's incredible, very inspiring, a father who was a neurosurgeon, and he would say this over and over again, and I didn't take it very personally initially, and I realised it's just actually word of wisdom, because demography gives you so much information, and you get this magnified view of so many structures in the skin that it's easy to be overwhelmed, but it's almost pointless if you don't have it on. And to provide some encouragement today. Next slide. So it's useful to have the same device that you're using, rather than sites people can share different models of dermatoscopes. I have all the slides have changed here, but on the left there was the Dermalite DL4, which is what I use for a hybrid device that I tend to use in a polarized function. But so you see a lot of these high-end devices in practices which are non-polarized devices requiring fluid. So it's useful to stick to the same device and then get used to the kind of image that you see in that device next. So what are the, it's not on the screen. So what do we see with dermoscopy? We can see epidermis and the epidermis quite clearly with our dermoscopes. Now, what structure within those layers can be seen? We can see pigment. This is an example of a pigmented lesion. We've got nicely laced like reticular network. It's a little blurry and smaller than that screen, but it's still a lace like lattice in the pigmented one. We can see vascular structures. So whenever you see pink or red, it signifies vasculature. Next slide. So the next slide is a schematic of a wide vessel, which is the typical vessel that you would see in the next slide. It's a typical vessel that you would see in a BCC. Which would appear. So this is a sign of an actinic keratosis. Yes, actinic keratosis. So you've got this sort of flecks of white seen there, and then this strawberry pattern. If you kind of step back, you can see this red pseudo network. These are the whole keratosis. One was also not today. So one of the vascular patterns, any vascular structures will have any type of arrangement and shown under dermoscopy. And the ones I'm going to focus on are lots of different patterns here. If you've got a H, you've got a branched vessel, these are the hallmarks of basal cell carcinomas, these arborizing blood vessels. You've got E, the comma-shaped vessels, these are seen in dermal nevi, a very common finding. And then you've got D, which is the hairpin vessel. These are very common in squamous cell carcinomas, that kind of looped type of blood vessel, which I do have an image on later. Dotted vessels, you can see in things like dermatofibromas, which is A, and then Bowman's disease, you get these kind of glomerular blood vessels, which are shown in box B. So lots of different patterns, and understanding those patterns helps you to diagnose lesions under endoscopy. Next slide. It's useful to understand that when you're looking at something brown, that the depth of the colour tells you where that pigment is in the layers of the skin. So black as a colour under dermoscopy tells you that the pigmentation is quite superficial and strong corneal. And as the colour of the pigment gets lighter and lighter brown, we're moving down into the layers of the skin, into the part of the dermis, and then lower down the dermis, lesions appear more blue or grey. So in a blue nevus, the pigmentation is deposited in the reticular dermis. So the colour that you see can give you a clue where the pathology is. And again, on the right, you can see the distributions of pigmentation. You can get linear pigmentation, pseudopods, round circular structures, and we'll get some real world examples next. So next slide. So what are normal pigmented structures that you might see in dermoscopy? Well, you might see, as I mentioned before, a lace-like pigment network. So in particular, so yeah, I'll describe this in my letters. Pigment network. Next slide. You might find pigmented globules. So these are kind of clumps of pigmentation. You can see in this lesion is a range of uniform lesion from, and then you've got this kind of arduous pattern. If you zoom in, there's no fine, sharp patterns here, but just a blur of pigmentation and linearness. Next one. And then a starburst pattern. You've got these radial spokes of pigmentation. Any adult with a starburst pattern pigmentation, you want to emphasize versus suspected melanoma. Next slide. Often findings of common vessels up in the top left doesn't kind of show through very clearly on the screen. Another benign nevus, I tend to see these on the scalps, the central hypopigmentation on the top right, and then again some uniform, regular looking nevi at the bottom, regular pigmented blotches on the left, and regular pigmented globules on the right. And all harmless and benign lesions. Now let's move on to the red flags that you might see. Next slide. So it's back to how often a melanoma might be diagnosed by a GP. It's useful in that situation to have algorithms to provide you with decisions. There's a number of amenities. We've got the kind of 6-point checklist, 7-point checklist. And you've got this one found in a paper, which talks about when you look at a lesion under endoscopy, have you got any reassuring features of common benign lesions like a set pain or a dermatous fibroma? If it's absent, move on to the next part of the algorithm. Is there chaos and is there a starburst pattern? If yes, you'll emphasize it. If no, you've got specific red flags to look out for. So there's numerous algorithms out there. So we're just going through some again some pearls now. Next slide. So let's go through some red flags. So we're talking about a normal thing, nice, regular, lace-like lattice across the lesion. If you look here, you've just got this lace-like pattern on the left, and it's absent completely on the rest of the lesion. So it's a non-uniform pigment network, and not only is it non-uniform, but can you see that the lines forming the network are very thick? They're not delicate like we've seen in the last image. Thick lines, which sets the right flag. Next slide. This is another example of an abnormal pigment network. You can see actually there's a network-like arrangement from the middle. You can see that the outside pigment network looks quite different to the pigment network in the middle, which is much darker. Pigment. Then we've got pigmented globules. We saw some regular pigmented globules earlier, which are reassuring findings, but if they're irregular, different appearances, sizes, and specifically peripheral pigmented globules, this was something that was taught to me when I was a registrar. Peripheral globules in a mole in a trial very normal because it's showing you that it's a dynamic mole that's growing and evolving, whereas that should not be a finding in adult nevi. So adult nevi with peripheral globules are in range for excisions. So you can see this lesion, you've got varying different shapes and sizes of the pigmented globules. It is a little bit difficult to see actually, and then you've got these kind of extensions out into the skin, those pseudopods at the edge. Next slide. Another red flag is looking for refractory structure. So this represents an attack by the immune system to attack the melanoma cells. So we've got that kind of pale white star-like area at the bottom of that lesion. There's kind of erythema, there's pigmentation, there's all sorts of colours going from there. But when talking specifically about the pale area, which is a red flag. Slide. Polymorphous vessels. This is a sign that can be used for any type of skin cancer, really. But we've got here, again, it's going to be a little bit difficult to see, but you can see a thick coiled vessel at 6 o'clock, just right at the edge, but further, you can see dotted ring vessels as well. Different parts of blood vessels is a red flag. So hence why a strong case for melanomas, people this blue white veil for segmented lesion. And not only that, here you can appreciate there are these kind of angular black lines. So whenever you get angular thick black lines, polygonal lines, that's a red flag. But this is a blue white veil. Next slide. This is more of the angular pigmented lines. If you just kind of zoom back and you can see in the middle of that lesion, you've got these kind of thick, lumpy angular lines. This is a red flag in pigmented lesions. Yes. Peripheral radial lines of pseudopods, a bit like that schizoid starbucks pattern we saw earlier. If you look at the side of that lesion, you've got this kind of outward stripes of pigmentation. These are kind of radial lines of pigmentation. That's always a red flag in that. And this is quite a useful sign to pick up. White lines in an inverse network. So we looked at a pigment network, which should be kind of lace like brown pattern. But actually, if you look where that green arrow is, you can see this lace-like pattern, but it's white. You appreciate it, yeah. And so we call it an inverse network, and that's a strong predictor for melanomas there. So white lines and an inverse network has been shown there. That red arrow there is showing small dotted vessels at the bottom of the lesion. Even without those structures, you can see it's a vastly asymmetrical, non-uniform pigmented lesion. Next slide. So this is a summary of those signs that we look for. There's 8 of them on there, and those 8 features are strong predictors of melanomas. So just a little summary slide there. Next slide. And there's no talk about dermoscopy without talking about seborrheic keratosis. It's probably the most common lesion that I see in skin cancer clinics. Clinically, these are stuck on really key things that tend to be well demarcated, brown, yellow, crusted nodules or plaques. And I think this is where dermoscopy has the most utility, because it really helps you to differentiate between something that's pigmented and seborrheic keratosis, because they're not always obviously questioned about this. So next slide. And I find if you can recognise any one of these features from dermoscopy, I will happily reassure the patient. And so it's just really useful, probably more to know about this slide, sometimes about flowers, they're so amazing. So you're looking at milia-like cysts. These are these milky yellow globules, you can see in that. So the first look at the two on the bottom right. These are called milia-like cysts or hallmark of seborrheic keratoses, meadow-like openings. Again, you can appreciate two images. Got these almost carotenorized bumps extruding from the surface of the cell K. So these are meadow-like, comedone-like openings. In the bottom left, you've got fingerprint-like structures. So these kind of delicate brown lines. I find if you can recognise fingerprint-like structure, it really helps you to differentiate between that and pigmented lesion. Then you've got this cerebral pattern, like the surface of the brain. So 4 hallmarks of CFAs. And so the basal cell carcinoma, what does this look like in dermoscopy? Without dermoscopy, we can see a fairly ulcerated nodule with hemorrhagic crusting, centre, side. With classical hallmarks under dermoscopy, when you are removing blood vessels. Often these are very sharp focus with dermoscopy because they're very superficial. And then focal erosions. These are the 2 hallmarks in BCCs. You can do the next thing. So down the blood vessel and then that superficial focal erosion right in the centre of that lesion. The acute side. What other structures might you see? I think a really useful tool is looking for an ovoid nest. Now, you can think of pigmented lesions only, pigmented structures only being in pigmented lesions, but actually in BCCs, you can see these little purple blue round points. It's actually highlighted in here, so a few times. To the branched vessel there. These blue grey ovoid nests are very common. That's why I spot them everywhere. Actually, again, it's really useful to know what they look like. You click again. Again. Yep, so I've highlighted where they are with those blue circles, and again, I don't know if you can appreciate the ovoid nests. And then again, BCCs can have pigmentation in them. So these are leaf-like structures to see. So they're quite delicate, leaf-like orientations seen on endoscopy. You can see it's very different to pigmented structure we saw here, pigmented melanomas, a bit more delicate, these structures. Next slide. And if you look at the top left, if you saw the MRI patient, you'd think it's an asymmetrical, non-uniform lesion. I think a giveaway for the BCC for me would be that it's a little bit shiny. There's a bit of a pearly surface, but then if you zoom in with dermoscopy, you've got lots of clear evidence there. BCC, you've got bright really beautiful branching vessel at the centre and at the periphery, with numerous ovoid nests, and you've got these leaf-like structures on the edge of it. So you can be 100% certain with dermascopic that is a pigmented BCC. Slide. And then similar to the leaf-like pattern, you can see spiral-like patterns on dermascopy. So you can start central dark components and then these little petals almost extending from that. They are characteristic of basal cell carcinomas. Slide. And that's another one there. We can see branching vessels. We've got these kind of leaf-like structures at the edge, and spiral patterns. So another nice example of BCC. What about squamous cell carcinomas? Under dermascopy, key findings for a squamous cell carcinoma are irregular white circles. White circles to help you to identify a peripatetic process. And irregular white circles are highly specific for squamous cell carcinomas. You will see keratin under dermascopy and then looped blood vessels as well. And this is an example. I just put this photo in because it's got a looped vessel. So at 12 o'clock, you can see this kind of hair-thin vessel on top there. And then I think there's some more on the 3 o'clock edge of the lesion. So hair-thin vessels are highly strong indication of squamous cell carcinomas, and we can see keratin there. It's flame, it's pink, and it's supposed to be a painful lesion. Next slide. And on the back of SCCs, it's useful to know what processes look like, because often these are referred as suspected SCCs, and actually the key thing here is no rapid change in the history. These are not tender active processes. You can never be tender. And on dermascopy, you're going to see an erythromatous pseudo network. That's what gives it that strawberry pattern. So if I ever see a strawberry pattern, I'm very sure it's an active process. You're going to see surface keratin. You might see the follicular openings, which are yellow, circles, and linear wavy vessels as well. And on top you've got a pigmented actinic keratosis. So I thought we'd just discuss some cases. Yeah. Next one. I think it does not look like it's, you can't see the structure very clearly, but I've got a 70-year-old female with a bleeding lesion on the right shoulder. Really, you can see all the features. Yeah, very used to for David. Yes, yeah. So it's a real giveaway with BCCs because the vessels are always flat focused. They're really, really well delineated fine blood vessels. So you've got numerous branching vessels there. So exactly, this is the base of cell carcinoma. So bleeding lesion on the right shoulder. The other thing I wanted to highlight as well, recent JAMA publication, they discovered this new finding after looking at series of globules. The non-pigment BCCs, and actually it's describing these clusters of yellow. That's right. It's describing these kind of yellow globules that are clustered together. This is relatively new characteristics journal paper. So you can see there in these BCC examples, these clusters of yellow globules on both the upper and lower row of images there. So it's quite a useful thing to know about. Actually, it's one of those things to you learn about something and you think, I've not noticed it before, and then you start noticing it. So I think it is quite useful. Next slide, please. So that 27 in May with a changing mole on the right thigh. Any thoughts?
very highly asymmetrical.
Yes, yes,
It's quite important.
yeah, yeah, exactly. So melanoma, you've got these little globules there, very different sizes and shapes. You really lost the, really size it next. So yeah, pigment network, your regular globules. Let's see. So this is an 85-year-old male, thrusting lesion in left forearm has been present for 8 months. Anything here? Yeah, that's right. Yeah, so really nice examples of ovoidness. Yeah, So just useful sometimes when you know, when you've seen something, that you can now comment whenever you kind of document these things. So yeah, there's no more there. There are these kind of spoken like it's like picking around. Yeah, this is context that they've used. It's actually obliterated the blood vessels, so you don't really have a kind of fine, focused blood vessels there. But I imagine it's used in the non-contact biopsy, but really size.
And you need more as well.
Yeah, right, yeah. Then here's a 50-year-old male, a mole on the back, uncertain duration, doesn't know if it's changed. Again, any thoughts? Yes. Okay, want to wrap up soon. So yeah, exactly. You've got the highly asymmetrical, you've got kind of resting out, so possible regression going on there. You've got a typical pigment network. It's looking different on the left side. It's all different shapes and sizes. You know, yeah, 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 I would totally agree with that. And if you again, so yeah, as for the startless areas, the core in the precautionary on the side. So yeah, I think some pearls for me are just taking your time. I think in time pressured environments, it feels like you can do it really quickly. But it's almost like, you know, the magic eye thing, where you just kind of like almost let it settle, and then all this stuff kind of pops out at you. And I find it quite useful just to say, right, here's a pigment lesion, so under the mosquito, I'm going to look at just pigmentation first. Then I'm going to move on to any vascular structures. Then I'm going to look at any extra structures, because as I say, there's a lot of information coming through. Taking your time, letting your eyes settle. It's helping us stop things that, you know, I'm not all of that in this talk. Some of it really is kind of training the eye to see these things. Repetition is practice, and it's so important. And it's also useful. A lot of these scopes now, the modern ones, for home and tackling, take photos. So you can keep photographs, refer patients, see what it comes back as, or as a group, kind of discuss endoscopy cases. So there's a lot more of that happening these days, actually, especially with Telegram, AI, all sorts. Yeah, and then this was a useful book, Jonathan Bowling, and got this nice illustrations, really simple, kind of simple dermoscopy book, which is a great foundation to build on. Thank you. Questions?
Screen sharing now, and then come back online. It's been having difficulty with some of the sound and some of the images because of the way they are set up. Both of this, I will see if there's been any questions on the phone. Well, the broadcast is dropping off. So, I've had some problems with the connection. Yeah, I think that's probably the main problem. This is we're just using volunteers for we're not into with a slide show. So we're using the same bandwidth to basically do the presentation as well as the stream there. So I do apologise for people having difficulty. If it was a good thing to I would say that the recording should go planning because if these people come to us all well, it's still recording something that should look out. Any guys got any questions?
No problem. So this like yes, well, this is a machine. You mentioned the seamless, which was yeah, so just use of different sunbash, it's like it's under the age of 35 as well. You consider my age for 75%. Huge, it's very big. And it's like there's a big surge now, sunbash use in a lot of places, some come back into fashion. So there's a different like cigarettes being labeled as savings, there's rooms, need to label these things, certain brand right, teenagers and maids, but it's not much. To the so speaking so policy, we see those things also the ones in patients who don't really just so just happen and which we found so not seeing items we see and we see
And skin cancer that we see in lots of the SCCs. And from what I understand, those the rates of those have changed. Perhaps maybe part of that is that if we're looking at UK data, they're probably going to get a sunshine potentially. And generally speaking, they tend to have factors as well. And so I've seen in dark skin individuals who've had transplants and who are on lines that are used difference. But in fact, the design
So we've had a few people say that they've had with the no more questions? No? Thank you very much for joining. And for those people online, I do apologise for you having any sound or video or listeners. I'm going to end the stream now. The recording of this session will be made available. And hopefully that won't have the audio and the vision problems. We've had with the streaming, so that can be closest to